All right, gang. Starting a five-parter here, and 256 slides worth. And we're talking about old people, which unfortunately is a primary user of our services. So we got to know about old people and how we have to do our little bit of changing of how we do things with old people, and we just need to make sure that we understand some of the changes. Now, again, some of these I'm going to go pretty quick through, but then there's some of them that we're going to be nice and slow and make sure we slow down and talk about it. And again, aging. Yeah, we're all going to do it. Our biological peak is 30. I would say probably nowadays it maybe go a little bit further, but again, but we start to lose things as we age. And again, and the thing is we're getting older and older. And by the way, uh, being in the county, the region that we're in, we have a lot of retirees here. Matter of fact, I'd say we're kind of disproportionate to that. We live longer, again, and they're expecting that level to rise as medicine is getting better, and unfortunately, that means people are living longer, which means we're going to see a lot more of these ailments. Gerontology is the study of the effects of aging on humans, and geriatrics specializes in care of the elder. And I would say in our region, probably that number is significantly higher that we go to old people. So again, again, retirement years is about 1/4 of the lifespan. By the way, and you got to overcome the societal label of old person. Well, and I've already used it, I think, 3 times before as we go on that. But again, if you've been to the retirement communities around here, they do a lot of things around the villages. There's things, all kinds of things to do all over the place down there. Okay. And by the way, one of the things I will tell you as kind of a side note here is, yeah, if you usually lose a partner, um, uh, you know, they think that they're impoverished or vulnerable, but again, in certain cases that might be true. And one of the real big fears that they have is being alone or being taken out of their home, and you may have to deal with that as part of your treatment care with them. Is you'll get there and it's like they're having something really bad, but they don't want to leave, and that's a definite possibility. Again, 90% who live alone choose to maintain their independence, and that's kind of an important part. They don't want to be a burden on themselves or to others, okay? And that's not every one of them, but that's a great deal of them, okay? And elderly do not often reveal their problem beyond their chief complaint. So getting good history on them can be, I'm putting it very politely when I say, a challenge, okay? Or worse yet, you get a gigantic dissertation, okay? Just remember that a significant amount of these people do live in nursing homes, okay? And it's very important to understand is that there's a dependent living arrangement, and there's all kinds of different dependent living arrangements. I've seen it from some really, really bad situations to some really independent. There are several good ones around the region where they have their own apartment, but they will come down and eat dinner in the dining room, that type of thing. And so um, they 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 may reduce their medicines, and this is something that's important that you're asking them when you're taking history on these guys. Are you taking all your medicines the way you're supposed to? Because what they may do is half dose it in order to save money, and again, because they live on a fixed income, and if that income doesn't cover their medication cost, they might end up doing that. And unfortunately, they're at risk for criminal activities. They're not as physically active. More importantly, they're not as mentally active. They're scumbags in the world that they prey on these people. They try to if you send us money, I won't send your son or daughter to jail. Dad gets about 3 calls like that a week. It's like, okay. It happens, okay? So EMS calls always stressful for an elderly person, and they may be confronted with multiple decision makers, by the way. And this is something that might happen that you're going to have to remember. You're not only treating the patient, but you're treating all of those other people as well. So apply to keep that in mind. We've already talked about in medical legal the difference between a living will and a do not resuscitate order, and we try to honor the patient's wishes. Obviously, if they're competent to do so, they still get to make decisions about their care. Okay. Just do remember that if the caregivers oppose treatment, keep in mind the possibility of abuse. And we'll talk about elderly abuse a little bit later with this. And yes, unfortunately, we got some people that abuse, or both financially and physically and emotionally. They actually, that's their source of income. So when you take their gravy train away from them, they're going to be rather resistant to that. Okay. If you think the patient should be transported to the hospital, you need to make every effort in which to make sure that that happens. Okay. And that might take a little bit more time than normal. Okay. And don't forget about most of these folks are on Medicare, and this has changed a little bit over the last, I'd say, 8 to 9 years. But remember, yeah, this is kind of a big one for them. Medicare will pay some of the bill, but not all of it, okay? So just try to keep that in mind, all right? Um, this is another problem that we run into is on the Veterans Affairs. A lot of these guys are vets, and they'll want to go to the VA because the VA subsidizes the care for these patients. They have 170 hospitals, they have 100 nursing homes, and usually they have a sliding scale for the fees. But you're going to get people that say, well, I want to go, I want to go to the VA to get treatment. And again, here, the closest one that we have is Randall McDowell, the VA center up in Gainesville. The problem with that is again, if it is true emergency treatment, by the way, the VA does pay for them to go to the local emergency room and then be transferred up at a different time. Okay, or a matter of fact, they've got their own ambulances. Some of the times they come and actually get them. Now, local governments, by the way, they do fund hospitals and clinics to provide care for the people that can't get the health care involved. The local governments also subsidize um, uh, local programs like for feeding and for transportation as well. Private insurers offer policies for long-term care, but they're extremely expensive. And again, hospice care is usually used for your terminally ill patients. Okay, the hospital care, when they make that statement there, and it has to do with payment and reimbursement, unfortunately, but they've shifted their pay dynamic after a certain length of stay, usually 3 days. They start to lose money at that level. And so that's why you're starting to see more of the home care being done, okay? The best things that we can do are probably preventive care issues with them, okay? Again, senior centers and Meals on Wheels, these are all organizations which they do that, so they'll bring in things. Religious organizations do a good job of this, and the national state associations also help for advocacy of these retired or older patients. The governmental agencies, again, refer to elderly as community programs. These are things that you're going to see out there. Again, and you stop and think about it, we do a lot of senior care things throughout the year in the EMS function, okay? Matter of fact, the real big one is your community care paramedics are kind of aimed at reducing the amount of times we have to go to our more elderly patients. So how do we treat these guys? And I think that's kind of they're a little tricky on that part, because sometimes where they say it's wrong is actually not what's causing the problem. And again, early warning is possible undetected medical problems. I think that's so very important to understand. Referred pains, general feeling of weakness or malaise. Okay, they usually have on average 6 medical disorders. Okay, disease in one organ could cause a problem with another one. If you've got massive kidney problems, you're probably going to have cardiovascular respiratory effects with it. Okay, so it might not, the complaint might not be just pointed to one thing. It could be a combination of things. And again, dizziness, weakness. How many times do we go to the calls with this? They're not eating. Their inability. They have no appetite. They can't pee. They're constipated, or they have massive amounts of diarrhea. Again, and remember that people. They use a lot of our pharmaceuticals. Again, 4.5 medications per day. And this doesn't include, by the way, medications, herbal remedies, vitamins. So that's a lot of drugs for these guys, okay? And what about when you start mixing drugs? Does certain drugs work against each other? Dr. A prescribes a drug, Dr. B prescribes a drug, but they work against each other, or worse yet, they potentiate each other, and now we've got major issues with that, okay? And then 40% don't take their medicine as prescribed, 35% experience some sort of medical problem because of that, okay? Stop and think about that. Just a little bit. So what do we do? How do we do this? And by the way, it might not be their own fault. They might take their drugs 2 and 3 times in a day when they're not supposed to. Okay. Again, is there mentation there where they can understand and know how to properly take their medicines? Okay. Again, these are things that can interfere with drug compliance. Again, having the fear of the toxicity can be a reason that they quit taking it. The duration of drug therapy is another one. Again, they don't understand how long these things last in their system. Well, you know what? I'm having pain. I'm going to take a leave. Well, 2 hours later, I'm having pain. I'm going to take a leave. 2 hours later, I'm having pain. I take a leave. You're only supposed to take one of those every 12 hours. So that's one of and the only reason I know about that is because, again, my mother-in-law started having abdominal GI bleeding because of it, because it was eating through her stomach essentially. So again, good patient-physician communication is absolutely essential. And again, but you need to ask your patient about this. They'll use the blister packs in order to open them a little bit easier. Again, these are the child-proof pills, if you will, but the elderly patients can actually get to them just a little bit better. So again, make sure that they understand the reason, and make sure that they understand and engage family or other caregivers with this to make sure that they're taking their medicines like they're supposed to. Again, some of the other things that can happen, you want them to have a good diet and good regular exercise. And the lack of mobility, by the way, I think that it's got both physical and emotional effects, okay? And by the way, that is going to decrease as time goes on. Remember, it's going to start to hurt things. Your arthritic patients, the joint pain that they might be having. Again, and it can lead to, again, poor nutrition, difficulty going to the bathroom. Again, the feeling old, okay? These are things that are very normal for them to go through. And isolation is another one, especially if you take away their driver's license. That's kind of a big one. Again, intrinsic is related to the patient. Extrinsic is motivated by the environment. And there is the possibility of physical abuse with these guys. And again, especially if your injuries are not matching the story. Okay, if you're going to a patient because of frequent falls, and again, and normally you haven't gone to this patient, you see extensive bruise where you shouldn't. Remember that we have trouble communicating. They have impaired vision. Their hearing is usually horrible. Again, and they have an altered sense of taste or smell, and by the way, they have a lower sensation to pain. They just don't feel it. Okay, the nervous system is, it's an older nervous system that doesn't pick up the pain. But yeah, we've still got to treat these patients, and how they're embarrassed to talk about some of their stuff. They, again, you got to respect the patient's dignity, and again, but you might be going to this patient, they might be covered, head to toe with feces because they literally can't get out of bed in order to treat them. They can have rashes. I had one lady that was literally stuck to her chair. We had to cut the fabric out of the chair because her decubitus had grown into the lazy boy. Okay. By the way, that whole area was gangrenous. A very horrible thing that we were having to deal with. So again, they can have all these consequences on sphincters, their GIGU tract, and it can affect all of the systems by doing this. And by the way, drug therapy can either stop up everything, or it can actually cause everything to go very well. And when I say that, I mean extensive diarrhea where they can't stop it, okay? So, in diarrhea, lack of physical sensation may produce bowel incontinence. So, again, they might just have a good old-fashioned BM on the stretcher. Yeah, it's lovely. It's one of those things. It's like, we got to deal with it, okay? But again, an old person doesn't deserve to wallow in their own feces. And one of the again, if they do it on your stretcher, it happens. One of the things I would do is hey, before let's put them in the ambulance, why don't we spray them? Let's put them in the shower, spray them off while we got the hands here. Let's get all this nastiness off of them. Wrap them in a sheet. Wrap them, bring their clothes. That way they can, again, we can treat them with some dignity and respect, okay? Other things that can cause constipation, by the way, your opiate use, and again, we like to give out pain meds to our older folks that are in pain. Again, diuretics can cause issues. Again, you pee it all out, you can't really poop, okay? And just remember that these can cause issues with constipation, which leads to the bowel obstruction, bowel pain, okay? We're going to get into the assessment on the next video, so we'll start with that one then, and I'll see you guys then.